So good evening students. Today I'll be discussing about temporal ECGs in an anterior wall MI. So recently that we managed in our hospital, and our hospital is not a PCI capable hospital. So many of you very soon will go to rural postings where sometimes PCI is not available next door. So what do you do जब आप लोग ऐसे दुविधा में पड़ जाते हो? So over the period of next few slides, I will discuss how to manage a anterior wall MI. So this person was a 54-year-old male. He was smoker, and with smoking we always take the history of what are the modifiable cardiac risk factors. So modifiable cardiac risk factors, ये history बहुत ही important है. So you have to ask about diabetes, you have to ask about hypertension, you have to ask about whether he has got dyslipidemia, whether he has a family history of early coronary artery disease, whether he had angina in past. So modifiable cardiac risk factors cover all this up. So he presented initially to a very remote setup at around 1000 hours, and with a history of angina since सुबह के 7 बजे 7 AM he started having this classical chest pain with a Levine sign. And apart from the chest pain, he also had diaphoresis and he had a feeling of impending doom. मैं मरने वाला हूँ डॉक्टर साहब. That is what the patient comes and tell you, and you will be absolutely be pale and you will be sweating, you will have cold sweats, and you can see that fear of death in his eyes. So whenever you encounter such patients, always be very sure that he is having something very sinister. So he was evaluated there in the peripheral setup. His heart rate was 20 per minute, BP 130/80, respiratory rate, temperature as mentioned, chest was clear. So why is this very important when you are encountering a patient of chest pain? I'll come to that. And over there a ECG was done and simultaneously a cardiac cocktail consisting of Disprin 300. Mind it, this is Disprin. This is not Ecosprin. This is not the gastric coated tablet. This is Disprin, and the Disprin tablet we always ask the patient to be chewed and then to be swallowed. Why do we do that? Because the action of ASA starts from the buccal mucosa. There is buccal absorption of ASA. So you should ask the patient to always chew it and then swallow it. Apart from that, you give an irreversible antiplatelet therapy. That is either you can give clopid if you are going for a primary PCI, then you can give ticagrelor. If you have got an IV form, you can give cangrelor. Prasugrel also can be given in as a dose of 60 milligram stat. Over here in our setup we give clopidogrel 300 milligrams, and subsequent to that a statin was added, that was 80 milligrams. So this was the initial ECG taken at the peripheral setup. So we know the definition of an ST elevation MI. ST elevation MI greater than 2 millimeters in the anterior chest lead, greater than 1 millimeter in the congruent limb leads. But in this case, apart from that, there another definition says कि the person may be having LBBB. LBBB. Fresh onset LBBB is also suggestive of an acute myocardial infarction. So in this setup, if you see what is an LBBB, how does it look like? If you see in the lead V1, it will look like a W. But does it look like a W? It does not look like a W. Rather, it looks like an M. Okay, so M is for right bundle branch block. Mainly all the right bundle branch blocks are normal finding in an individual. Majority of the right bundle branch block you will find in healthy individuals. However, because he has presented with a chest pain, we had to relook at this ECG, and you find that there is a Q wave over here, a small Q followed by this M pattern. Okay, so when you get an established qRBBB, it is suggestive of a massive anterior wall MI. Massive anterior wall MI. In majority of the cases, proximal LAD is blocked. So you should have a very high index of suspicion when you see a qRBBB. This Q, small q followed by a RBBB pattern. Okay, this M pattern. Fresh onset LBBB, yes, that is definitive for a massive anterior wall MI. Generally the patient presents with failure or in shock, and it has to be, they have to undergo a PCI. Treatment of all MIs are PCI. Whatever you do in a PCI non-capable center is just a bridge to PCI. The final treatment lies in PCI. So over here, if you see, there is a RBBB pattern. Now very carefully look at the axis of the QRS complex. So with the RBBB, with the qRBBB going on, you have got a left axis deviation, which suggests that there has been another bundle branch block. In this case, it is LAHB. So we will stick to this MI, and there has been a massive elevation of the ST. If you see, massive elevation, they have just become a shark fin type appearance. Okay, so this, if you see in the anterior wall, is full of ST elevation till V3, and now look at V4 and V5. The ST has just started coving up. Okay, and now look at the rhythm. When you look at the rhythm lead, you should see that every P is followed by a QRS complex. Okay, so now we have got a qRBBB anterior wall MI. So now the patient was zoomed off from there immediately, and from that peripheral center to this center, the time taken is roughly around 20 to 30 minutes. So on arrival, heart rate now 120 per minute, BP still holding, and chest is clear. Now why is this chest part important? Because in clinical classification of MI, when you are always conveying it to a higher center, Phillips classification, as we call it, Phillips classification, it is divided into 1, 2, 3 and 4. In first, there is no failure, chest will be clear. In the second one, the patient is in failure, and 1/3 of the auscultatory field will be full of bibasilar crackles. In this, the failure increases, and you will find the full auscultatory lung field, the full lung field greater than 1/3 will be filled with bibasilar crackles. And fourth will denote a cardiogenic shock. That is, the pump of the body has failed and the perfusion of the tissues are hampered. So this patient was in Phillips 1. Now here he comes to us. Now what do we notice over here? That there has been development of Q waves. These Qs have already been developed, and if you see now V3, V4 were spared. Now their ST elevation has also started. There has been a progression in the ischemia. So with this ECG, there was sacrosanct of an anterior wall MI going on. So we took the decision of thrombolizing him, because the PCI centers were very far off. So contraindication to thrombolysis was ruled out, and subsequently we plan to thrombolize the individual. So how do we start the process of thrombolizing? Firstly, take a consent from the patient that we are going to thrombolize. These are the rule out the contraindications of thrombolysis. And once you have done that, I always prefer to place the patient on PPIs. Subsequent to that, antiemetics, because I will be giving them some emetogenic drug that is coming just next. So next was morphine. So morphine over here, it has got multiple actions. The first action is it will cause pain relief because patient is in excruciating amount of pain. 2, it also acts as a vagolytic. So the vagal tone goes down, so the heart rate decreases, and it also causes decrease in preload. So it helps the heart to perform better. The third medicine that I gave this, the fourth medicine that I gave this patient was LMWH, low molecular weight heparin. Low molecular weight heparin is generally given subcutaneous. However, in a setting of acute myocardial infarction, it is recommended that the modality be changed to intravenous route to achieve the desired effect. Where does LMWH act? It directly acts on factor 10. So LMWH was given IV stat to this individual. Subsequent to that, I gave him a small dose of hydrocortisone. Now, why was hydrocortisone given? Hydrocortisone was given because the thrombolytic that I will be choosing later, that I will talk later, was streptokinase. Because in Indian population, we have already got preformed antibodies to streptokinase, and it may lead to an anaphylactic reaction. So never give a test dose for streptokinase, because when you have to give, you have to give. So just give him a hydrocortisone and then you start the infusion of streptokinase. The second drug, another drug that was given was a beta blocker. Over here again, the modality was intravenous. If you don't have it, start with the oral drug. The idea is to decrease the heart rate. How much to be decreased? It has to be decreased to be kept between 50 to 70 per minute. So what will happen? The diastolic phase will increase. There will be good supplies through the coronaries, as well as there will be good filling in the heart, and so the CO will increase. The cardiac output will increase, and the work of the heart will go down. So we gave him 2 shots of metoprolol depending upon his response. It was repeated after 15 minutes, and we got the heart rate not down to 70s but somewhere around 90 per minute. So this decisions of where to maintain the heart rate has to be very judicious. So now we took the decision of thrombolizing, and the thrombolytic chosen was streptokinase. Now how much streptokinase is to be given? 1.5 million units was dissolved in 100 ml of normal saline, and it was infused, it was planned to be infused over a period of 45 minutes. So streptokinase over here was taken because of the availability, and secondly it is cheap. But with advent of newer thrombolytics like tenecteplase or retiplase, the use of streptokinase has come down. Tenecteplase is a single bolus dose. It is a bolus dose. In a person less than 80 kgs, 40 milligram is given. And for streptokinase, it becomes, I might say, it is a negative aspect of that streptokinase, that it is to be infused over 45 minutes. So 45 minutes, when time is hard, 45 minutes is already wasted in giving the infusion, and then it will start acting. So 45 minutes gone, preformed antibodies are already there, chances of reactions are high, but and it is moreover a non-specific thrombolytic. That is, it will cause destruction of thrombus anywhere in the body. So if it is a good thrombus which is sealed off just a small cerebral hemorrhage, it will cause a big hemorrhage over there. So streptokinase, so tenecteplase and retiplase are preferred these days. Retiplase has got one plus point over tenecteplase is that it is not weight based. It consists of 2 bolus doses, 20 to 30 minutes apart. So as the infusion started, after around 30 minutes of infusion, the patient started complaining of, though there was relief of chest pain, but the patient started complaining of palpitations. So you see this ECG, what has happened. What you see over here is a rhythm. If you see the rhythm lead over here, you see these are all P waves, and these P waves are followed by a QRS complex, and if you look closely as this QRS complex is, there is a septal depolarization and then there is a ventricular depolarization. But if you look at these complexes over here, they are very different from this QRS complexes. So what is happening over here is there is no P wave, and this is a ventricular rhythm, a subhesian ventricular rhythm, and these are the markers of something that we call as accelerated idioventricular rhythm. Okay, so we come to the question is, what are the markers of successful thrombolysis? Now you have given a thrombolytic agent, you have given tenecteplase, retiplase, actylase or streptokinase. So in 90 minutes there should be few of this. First, relief of chest pain. Two, inversion of T wave, early inversion of T wave. 3, presence of reperfusion arrhythmias like AIVR. 4, settling of ST. If the ST comes down at least 50% of what it has been elevated to at the maximum time, these are early peaking of cardiac enzymes when you can do cardiac enzymes every 30 minutes. So these are a very few markers of what I can say is successful thrombolysis. So a successful thrombolysis was going on, and then this happened. The monitored showed, sorry, this video is not working. So the monitor showed presence of a unstable cardiac rhythm. So we did an ECG. Now you look at this ECG. What has happened in this ECG? Look at, where do you look for the P waves? For P waves, you look at the lead 2 and lead V1. Can you see any P waves over here? Can you see any P waves? There is complete absence of P waves over here. And then what has happened to this QRS? Are they regular? Is this distance equal to this distance or this distance? So there is absence of P wave and irregular RR interval. So what becomes the diagnosis? The patient had AF. Now with AF and anterior wall MI, this is a very dangerous combination. The mortality is, as such, qRBBB is itself suggests a very high mortality. Now with this all, it became a tremendous combination of a lethal entity. So now I was in a fix. What is to be done? So we decided to cardiovert this patient. I was planning for a synchronized cardioversion. Last time I have told you, what is a synchronized cardioversion? So cardioversion was planned, but however we observed that on the monitor the rhythm changed into atrial bigemini and trigemini, hence the plan was abandoned. Now just look at this rhythm. So you find that the P waves have at given point of time they have returned. The P waves, if you see in other leads also, the P waves have returned. Okay. So once we have gone through all this and there was intermittent AF, so to stabilize the rhythm, what we did was we have given a slow loading bolus of injection aminodarone over 15 minutes. How is aminodarone given in an AF? Aminodarone is given as a 150 milligram bolus. In other AFs I am talking about, followed by 1 milligram per kg per minute into 6 hours and subsequently 0.5 milligram per kg per minute into 18 hours. That is how you load a patient with aminodarone when you are managing, when you are trying to chemically cardiovert an AF. But here my main intention was it should not deteriorate into a further lethal kind of a rhythm, and with this bolus itself the rhythm stabilized to normal sinus rhythm with intermittent bigeminy. If you see, the majority of the QRSS complexes have got a P wave. Every QRS complex has a P wave, except when you come over here, there are ventricular bigemini and trigemini type pattern which is being followed. So apart from this, majority of the rhythm had already stabilized. So we kept the patient under observation for 18 hours. Subsequently, when the roads opened up after the rains and when the roads opened up, subsequent to that we sent the patient to a PCI capable center. But before we send him off, we did a bedside 2D echo and we found that he had a massive anterior wall as expected, and his apical, anterior septal and lateral wall were already scarred and akinetic, whereas the mid septal, anterior septal and anterolateral was hypokinetic. LVUF was around 20%, there was no clots and PE. So patients were finally referred to a PCI capable center for further management. Over there he has already undergone a PCI and he was found to have a reclinialized LAD, proximal LAD, and he is still recovering. The stunned myocardium is still recovering, and we hope that he recovers and comes back to us. And dear students, I am getting a lot of suggestions that sir, why don't you do a talk on snake bites, scorpion bites, then stroke, cortical venous thrombosis. We'll be doing it subsequently over a period of time. Rome was not built in a day. So as for today, good night.